everybody. We have a pretty full house, and we're delighted that everybody's here. I'm Eileen Zweig, and I am with the Plaza Health Network, and this is a special program for us called Plaza Healthcare Cafes. We're doing a series of education programs throughout our community so that seniors have the opportunity not only to speak with the experts on a variety of topics, but to learn and have a chance to have all of your questions answered on whatever topic we are presenting. I'm pleased to introduce to you first Dr. Jason Raddick, who is one of our doctors and an expert in pain management, and Dr. Francis Berman, who is one of our psychologists and also an expert in the psychology of pain management. So without further ado, Dr. Raddick.
Thank you, Eileen. I'd like to thank the Plaza Network, Heber Homes specifically, for sponsoring this series. I will give you a little brief background about myself. I'm an internist in private practice in Aventura area as well as Miami Beach. I'm also the medical director of the Sinai Plaza Rehab and Nursing Home. My job there is more administrative, but I have patients there as well. And as Eileen mentioned, I mean, I'm a full-time internist, but one of the areas that we tend to treat, where a lot of my colleagues tend not to treat, is pain. And that becomes a source of problems for a lot of our patients, because either they go from doctor to doctor looking to get help for their pain, or they self-medicate and trade their pain medications. Oh, this one works. And we kind of laugh, but it happens so regularly that it's become an epidemic in Miami-Dade and Broward counties, where you've seen in the news, on television and in the newspapers, about pill mills. And those are pain centers that were sort of created initially to fill the need for chronic pain syndromes, but ultimately in this area became a place where a lot of people were just filling their drug habit. So because of that, there's been a pullback from the general medicine community in terms of treating pain, because there are new state regulations regarding how patients are prescribed pain medications. And as a result, patients aren't being treated the same way again. And when I was in my training, which is not that long ago, but I graduated from the University of Miami, and then my internal medicine and pediatrics combined residency at Jackson, and did a chief medicine year as well. Our training was that pain was considered one of the vital signs, the 6 vital signs. So we had blood pressure, heart rate, height, weight, temperature, and pain. So it's considered a vital component. And on every intake, every time you should go to the doctor's office, people will ask, are you in any pain today? And that's, there's different pain scales that people use. They'll say from 0 to 10, but pain is a subjective feeling. I mean, how much pain one person has. I mean, when you drop something on your foot or you stub your toe, that may be, it's killing me, to, it's not that bad. So everyone perceives pain differently. So I just want to get a sense here in terms of what people understand and believe the words that we use to describe pain are. So it's a little bit interactive. In this large of a group, I mean, if you sort of shout it out, and I'll try to recognize you. Give me words to describe pain. Anybody? Unbearable. Unbearable. Okay, great. Shooting, excruciating. Dull, burning. Throbbing. Stabbing. Sharp. Aching. Right? Hot, cold, numb. I mean, you're describing all the pains that we hear of. I mean, and the reason that we use different words, it goes more into the science of pain, which, although this is not a medical lecture, to understand what people experience with pain, whether it be yourself or a loved one, to understand that, I want to give you a little of the science behind it. And I'll make it as when I do lecture around the country about pain and pain syndromes and stuff like that. And even to my medical colleagues, I sort of had to make it as basic as possible, because the truth is you go into the deep science and people start falling asleep. So, but the simplest part is to understand that pain, the reason we use different words to describe it isn't just because it's what we were taught to say. It's because there are different nerve fibers that may be affected. Some actually transmit a pain signal that is a burning pain. Some may be a shooting pain. Some may be the numbing, tingling, cold sensation. Some is aching, and each part of our organs, which have the nerve endings on it, have those pain fibers. So depending on which pain fibers may be affected, may actually be why we're saying how much pain we have. The second thing is our tolerance to pain, our understanding of why I say it's a 2 out of pain, and you've got the same injury and you're saying it's an 8 out of 10, 10 of pain, is the pain pathway, and I'm going to explain that in a minute, but the pain pathway ends in our head and comes back. That's modulated by a lot of neurochemicals. The best way of thinking of it is, if this is an electrical system, there may be more wiring or less wiring sending those signals up and back. And if someone just has less wiring, or there's something that's dampening or lowering that pain response, it doesn't hurt you as bad. In fact, the best example I can give of that is, anyone know, without sharing your own medical problems, a diabetic who's had an ulcer on the bottom of their foot and they didn't know about it? Right? It's a very common common thing we see. I mean, you would think, boy, I got a paper cut in that hurts like anything. They can have a hole in their foot and have no idea. And it's because of the pain syndrome, the neuropathy, the damage to their nerves, that their pain signal's been eliminated. So it's not like they're ignoring their medical problems. They don't know they have it. So in different settings, we may have more pain or less pain, and that's important to recognize, because either for yourself or for someone you're treating, a patient you may be treating, or a loved one you may be treating, when they talk about their pain, I don't want you to think, oh, they're looking for pain medicines, or they're looking for something, or looking for sympathy. You have to recognize this could be a real thing, and everyone perceives it differently. The second thing is that in terms of pain, there's 2 types that we like to think of, and there's actually a lot of subtypes. But there's acute pain, so pain that lasts for less than a month. And that's just sort of you've had surgery, it's the post-operative surgical pain. You broke a bone, it's the pain until you heal. But it's typically pain that goes away in under a month. If it's beyond that, if there's something that causes a painful stimuli for more than a month, and actually it's usually more than 3 months, but it doesn't have to be continual, it just has to be ongoing. So I'll throw out a question here is, what are some of the chronic pain syndromes you can think of? So people their pain lasts forever. The disease process that's causing the pain isn't getting cured, and so they have pain intermittently or for long periods of time for more than 3 months. Anyone? Arthritis, big one, right? Obviously, chronic arthritic pain. I mean, we see television commercials about all the different treatments for arthritis and arthritis pain, and there's 2 parts of it. One is the joint destruction. The second is the pain that's associated with it. It's horrific. What else? Excellent. Back pain, chronic low back pain, the #1 reason why patients go to their primary care doctor. What else? Migraine, chronic headaches. And people think, well, it's a short-acting headache. It happens. Some people get headaches and headache syndromes, if not on a daily basis, certainly on a monthly basis, certainly 3-4 times a month, many times with trips to the emergency room, many times where they're, reaching for something to relieve the pain. Headache syndrome is another big one up there.
Nerve damage.
Nerve damage from different things, right? So give me examples of that. Fibromyalgia. Excellent. Fibromyalgia, which years ago used to be considered a diagnosis for only the crazy. It is not. It is not. Actually, it's been proven that there are when they looked at electron micrographs, which are detailed pictures in the body, that there are definite changes to the skeletal muscle system that support the diagnosis of fibromyalgia. Now there's specific diagnostic criteria, and we'll go into one of the treatments for fibromyalgia used to be, as a standard, a psychiatric medicine, antidepressants. And people thought, again, it's because, well, it's in their head, so that's why we're going to give them those medicines. It turns out, and I'll explain to you why when we go into the medicines that we use to treat pain, why antidepressants are actually a good drug, but not because of the reason of because they're crazy. And then other nerve damage things. You know, you mentioned it. So I mean, but diabetic neuropathies, people have like the burning, shooting pains from that. Anyone know anyone who's had shingles before? Yeah. Yeah, pretty nasty, right? So the acute side is that first month where you have the shooting pain that starts before the rash, then you have the rash, and then after the rash goes away, some people have that chronic, that same pain last forever. Not 24/7, but month after month, year after year, an intermittent shooting, burning, cold sensation that can last the entire time. And it's very debilitating. And it actually there's literature showing that untreated pain syndromes, and maybe Dr. Berman will sort of cover that as well, you know, besides leading to things like depression, I mean, if it's so severe, I mean, people have taken their own lives because they can't deal with the pain and no one else is addressing it for them. So it's a real thing. Is there a question?
No, comment. That it's really scary because there's so many drugs that are prescribed for pain have side effects. So you're a little leery about it.
Absolutely, and I think that's one of the best reasons for having these type of talks is to understand what are the other options besides the pain medicines that have side effects, or what are their benefits and how do we minimize those side effects or minimize people getting addicted and all the other stigmata that you think of. And we will get into that, so thank you. Let's see if we covered everything. You know, another one that's a big, talking about chronic pain syndrome is from spinal stenosis. We talk about back pain. Sciatica, which is the nerve thing. And also even osteoporosis itself isn't painful, but it very often causes compression fractures. So chronic cracks in the spine, which are, I mean, has anyone broken a bone? I have. I mean, it hurts. It hurts, rib pain, right? I mean, it hurts. So imagine a chronic broken bone in your spine. I mean, that's a very painful experience. All right, so I briefly mentioned the pathophysiology, the sort of understanding the pathway of pain, but let me explain it a little bit more detail. Basically, it goes, we sense it first, and that's the sort of peripheral, and that could be from anywhere. It could be from what's on our outside of our body, like I'm touching the table or I cut my finger by accident, to inside pain, an organ is swollen, like the appendix or the liver swelling, the heart attack causes pain because there's pain fibers there. Then it has to get to my brain. So it has to travel through peripheral nerves from the outside to my spinal cord, and from my spinal cord up to my brain, and then from my brain it has to go back down to the spinal cord and to wherever to tell me what to do, or how I should react, or should I say it bothers me or not bother me. And so it's a pretty complex process, but it's pretty much, as you can simplify it in that manner, that there really is as little, we want to make it, there's a lot more going on, but in terms of treatment, if we address any one of those pathways, or all of them, we can figure out how to manage pain. Not to cure it, but manage pain without, with minimizing side effects. So from the periphery, the idea is if there's a burning sensation on my arm, and we'll go to shingles as an example, postherpetic neuralgia, where that's the lancinating shooting pain in the area where my rash used to be, that nerve is inflamed. So I could treat that in one place by putting something directly over the nerve. And so that's one option. The second one is when that pain signal is getting up to my brain, is before it gets to my spinal cord, it has to cross over. And it's like a junction box if you're thinking an electrical system. If I can block or decrease the amount of transmission of that signal from the periphery up to my brain, even though it's still bothered on my arm, it may decrease the pain sensation. And then the last place you can do it is up in the brain, and that's either directly where the pain signals end up, and they affect different receptors in our brain, and that's actually where antidepressants come into play, is because the same fibers that travel up our spinal cord that carry the pain receptors end in the same area of the brain where our emotions are. So that's why depression and anxiety can precipitate or worsen the sensation of pain, or make it, or vice versa. I mean, people talk about a runner's high, and someone who's done an athletic, ran a marathon, and they came back and they feel fantastic. Their body has just been abused. They just ran 26 miles. I don't know, I walked 5 miles and I'm not feeling fantastic. But I can assure you when they get through that, because the neurotransmitters in their brain in that same area make them feel good, it releases endorphins, and that's sort of a feel-good hormone, and that's what makes them feel better, because it's controlling their emotional state. They're happy, the pain signal is decreased. So antidepressants, although we didn't know why we're using them in a setting of fibromyalgia, work for the setting of those patients because they improve our mood. Now, as far as other medications, you've heard of patients who may have been on for pain, seizure medicines like Neurontin or gabapentin or Lyrica. Now they work because they work at the transmission level from the spinal cord and the periphery. So if you can decrease that signal, as I mentioned, you're decreasing the amount going up to the brain so it's perceived. And lastly, besides the up in the brain area, besides things that make us feel good for emotional medicines, the pain medicines, and there's different classes, also work up at the brain. And they work at the brain about how much of the pain is perceived directly or how much of the response to that pain that goes to the rest of our body. So in medical school, we're always taught, do no harm. The first thing we should do is do no harm. So in terms of taking medications, before you get to that, you should look at, are there non-pharmacologic options? And there are a ton of non-pharmacologic options, a lot of them with evidence-based medicine, so support, proof that they work. The biggest one probably being physical therapy. Physical therapy in the setting of chronic pain syndromes, arthritis, spinal stenosis, low back pain, helps more than or as equal to a lot of medications in terms of relief of pain. However, sometimes it's not enough. Sometimes you need other things. Other non-pharmacologic things would be, besides exercise, acupuncture. What are some other options? Non-medicine for treatment of pain. Yoga. Yoga is a big one, actually. Meditation and Tai Chi, absolutely. You know why? Because they work up in the brain to decrease our perception and how we handle the pain. Absolutely. Deep breathing exercises. Anyone have ever heard of biofeedback? Yeah. Biofeedback works by sort of training your brain into recognizing your heart rate, your breathing patterns, to sort of, when you have the pain or whatever it might be that you're trying to regulate, blood pressure as well, to sort of control that, be aware of it, and slow it down. So yeah, there's a lot of other options. You have something else?
Yeah, what's a natural way to get your endorphins to kick in?
Exercise. Exercise is the best. Exercise will actually help relieve, but it doesn't have to be in strenuous. It doesn't have to be in, I have to run the marathon. It can be in the yoga. It can be in any pleasurable activity. And if you had a deep meditation or a yoga, and you felt like you accomplished something and you feel good afterwards, that's what releases the endorphins. Walking, a healthy, brisk walk. I mean, anything that's going to make you, take nice deep breaths, and you come out and you go, I feel better.
Water. Halfway exercise or water.
Any of the exercises, and especially in people who have arthritis, who have difficulty with mobility specifically, the aqua therapy helps because it gives them the ability to be more free. I mean, there's less weight bearing. Question back there.
No,
Is there any chance?
mediation is also.
Is there any chance to prevent shingles?
There is a shot to prevent shingles. The understanding is that shingles is because of a reactivation of chickenpox that we probably have all had in our youth. And why some people get it and why some people don't is more related to our own immune status and our own health. What's a stressor for us. It doesn't have to be a physical stress, it doesn't mean a health stress, it can be an emotional stress, it can be a physical stress. And somewhere in our life, our immune system may be low enough that it reflares and causes shingles. The idea behind the vaccine is, before that happens is to give yourself the virus again, and it's a modified chickenpox virus, to re-stimulate your immune system to try to build the antibodies to protect itself again. It's not 100% foolproof. People can get the shot and a month later or 2 years later still get shingles. And if you've had shingles, you can still get the shot because you're still at risk of potentially getting it again, depending on your own immune state. Now, the last few things I want to talk about before I turn over the microphone to Dr. Berman are the medication options. Again, as I mentioned before, we talk about do no harm. So we want to pick the things, the medication options that are the least harmful, least side effects, the least baggage associated with them. So the easiest ones to think of are topical, things that we rub on or apply on the skin. The least amount of systemic absorption, so the least amount of side effects that my brain may get or my organs may get. So anything topical, and there's plenty of over-the-counter creams that are topical, including the like Aspercream and Bengay and Biofreeze. There are prescription versions, things like topical lidoderm or lidocaine patches, because they all sort of have a topical effect. There's also topical non-steroidal anti-inflammatories, those topical medicines that include almost like a topical Advil, where someone's getting a little bit a topical Advil, where something like Voltaren gel or Pennsaid, where patients are actually applying an anti-inflammatory, very useful in arthritis, over the area that's inflamed or irritated, and that's what's causing the pain. The next step would be the ones that are have the least amount of side effects. That's in that class that I was mentioning, which are the NSAIDs, non-steroidal anti-inflammatories, including things like Tylenol, acetaminophen, and then as you know, Advil, ibuprofen, Motrin, Naproxen. But even though it's over the counter and we can get a whole bottle from Costco for 1,000 pills for $5, they have side effects. Tylenol has a side effect. It has a maximum dose you can take in a day before it's toxic to you. And the same thing with the non-steroidal anti-inflammatories. I mean, they can cause bleeding risk. They can affect your kidney function. So they're not without side effects or problems, but they do help. And if you can kind of use combinations where you're minimizing one because you're using a topical and you're using something else, you can be more sophisticated about treating your pain. As you sort of advance up the ladder, there are the other classes of medications that are, again, the ones that affect the anxiety and depression stuff. They're the seizure medicines like the Lyrica, the pregabalin and gabapentin, which help sort of modulate and decrease the amount of pain signal transmitting through the body. And there's a whole host of medicines in that class. And then lastly, which is what you were alluding to, are the medicines that sort of have the other side effect profiles, the abuse potential, the whole pain clinic, pill mill concepts, the opioids, which are the Percocet and Darvocet and Vicodin.
Sir, you mentioned Tylenol.
Yes.
What about the generic of Tylenol? You go into CVS or Walgreens and get their equivalent.
Acetaminophen is the generic of Tylenol. Tylenol is just a brand name. Acetaminophen it has the same potential. It has a toxic dose. You can't, you shouldn't go above 3 grams. Certainly no more than 4 grams in a day. Most capsules are pills are somewhere between 325 to 500 milligrams a pill. So people take 1 or 2, so up to 1,000 milligrams. But once you start hitting the higher dose, you have the potential risk of affecting liver. And people don't realize that when they take a medicine like Darvocet or Percocet or Vicodin, all 3 of those, which have a opioid in it, also have Tylenol in it. They have acetaminophen in it. And so they're taking that regularly, and then they have a headache, so they take a Tylenol on top of it. They have a fever, they take a Tylenol on top of it. They're really sort of exceeding their doses. So, yes?
Is Darvocet back in the market?
No, it's off the market. But trust me when I say someone still is writing, people are still writing. I just saw a prescription go out the other day. Yeah, they tried. Yeah, it's Darvocet because of its, again, the side effect profile. The as it was broken down and metabolized in the body, the metabolites were more toxic than the drug itself, and they sort of lasted a long time. Yeah, it's not out there, but a lot of people still have, people come and they list medicines that they're on because they got the prescription filled a few years ago, and they're still taking it. So there's nothing wrong with using the opioids, the higher class, the stronger medicines, but realize that it has to be in a modulated area, and it should be monitored by a single doctor. Now in the state requirement, and I think Dr. Bremen is really going to talk about that, the doctors, even myself, will require a pain contract saying that if you're getting your pain medication from me, or any of your controlled substances, including sleep aids, then you can't get it from anyone else. And that's sort of a statute that sort of came down through the government because of the pill mills that sort of spawned off in Broward and Dade counties, that the state and the DEA are really looking at who's getting the medication. And here I am talking to a young senior citizen population, and you would think, well, that abuse potential doesn't happen there. It happens everywhere. Everybody's at risk. And so I think it's important to recognize that, and this is, don't ever take offense when your doctor says you have to sign this promise that I'm not going to do it, or ask you to do a drug test, because in our own office, we've had patients who are filling and have been forever, their pain medicines all the time, month after month after month after month, every single time. And when they drug screened them, there was no medicine in their urine, which means they were sending it to somebody else or giving it to somebody else. And so, I mean, that's in the Miami Beach, Aventura area, so that's happening. So it's real. The last point I want to make, and then I'm going to turn over the mic, is if someone has a chronic pain syndrome, and one of the ways to decrease the chances of having pain medication problems is, if you have a chronic pain syndrome, you should be on a longer acting pain medicine. By being on the short acting medicines, as I sort of mentioned, the Percocet and Vicodin and stuff like that, and you need it every 4 hours, every 6 hours, or say you need it 3 or 4 times a day for whatever reason, but it's not every single day, but it's 5 days a week. You're basically trying to decrease the signal, and then it wears off. Trying to decrease the signal, and wears off. That up and down effect, that modulating effect, is what makes it work less, and makes it work that you need more of it, and is what creates the sensation of requiring more medicine, which begets the higher doses, and the higher doses, the side effects. So if you are on a medicine, or you have someone who's has chronic pain, and they need medicine, there are definitely tons of options, including those other ones, but they should be on something that's more round the clock, providing round the clock pain relief, even on the few days that they don't need it, if that's what it is, so that you are not creating that up and down monster, which makes them start craving more of the medicine. By doing that, you'll minimize some of their side effects, their abuse potential, and treat their pain. Now I'm going to turn over some of the other consequences of pain. Is there a question over here?
I'd like you to talk just very briefly, like Vicodin, Percocet, and Percocet. And I had to take that. I had some serious dental surgery. And he also had me take Advil. How was that combination?
No problem whatsoever. They're different classes of medicines. The Advil has an anti-inflammatory effect as well as analgesia, which means to decrease the pain. And certainly in the case of dental, but arthritis as well, one of the components of your pain is swelling. So by decreasing the swelling, you can decrease the pain. Different class of medicine is the Percocet and stuff. So it just addressed that pain in a different pathway. So totally safe.
I had a while ago a root canal, and they gave me Percocet, and Advil, the same thing. One other question I have with Vicodin is, how many days, what are the major side effects that you have to be concerned about, and what is the maximum days do you think you should take the Vicodin?
Okay. Excellent questions. And this goes to side effects of all the opioids as a class. Most common side effect is constipation. Itching is another one, rash, sedation, sleepiness, making you sort of to really knocked out. Now, but the whole nausea, I mean, but it can go down the gamut. I mean, you can, you know, if you listen to any commercial advertising, whatever they are, and then says, this may cause, and it lists everything that you know and can say, that's true for the classes as well. But the more common ones are constipation, sedation, the itching. They're not allergies to it. A lot of people complain when they were in the hospital, they received morphine and they started to itch. It's something that happens. It causes a release of antihistamine, which causes them histamine, which causes them to itch. So it's not really an allergy. But if the constipation becomes such a problem that you're increasing your pain by being, you know, backed up, then that's a problem. I mean, we try to address those things, being on a bowel regimen of some sort with stool softeners and laxatives. And sedation. There is no maximum dose to how much of the opioid you can give. There is, when those combination pills, of how much of the Tylenol component they can get. So the number of pills depends on the strength and the combinations. But the opioid, there is no ceiling to how much until you limit it back off based on the amount of side effects they get. And you'll minimize that by doing a long-acting as opposed to sort of bursts of high and low. I always say if someone needs to be on a short-acting medication for more than a few months, that they're taking on a somewhat daily basis, then they should be on a long-acting one. I mean, I don't expect your fracture of your hip to heal in 3 weeks and be done with it. The surgeons believe you and tell you that, but the reality is you're going to have a lot more pain for a fair amount of time. But if you're going to be in an extended period of time, you're filling that same prescription that says, you know, 1 or 2 pills every 6 hours as needed, and 1 month later you've already gone through the whole prescription, and 1 month later you've gone through the prescription again, then you're taking that 60 pills or whatever it might be, or 90 pills in the month. That's someone I would seriously consider putting on a long-acting.
What would be a long-acting one?
So some of the same drugs, the oxycodone, morphine, exist in long-acting formulations. So MS-Contin, Opana-ER, Exalgo. There's a whole host of them that are long-acting. The reason people don't know them, because there's the abuse potential, although it exists because they're opioids, doesn't have the street value. Nobody cares because they're not. That's not what everyone knows. Percocet, Vicodin. I mean, and they exist for we didn't even mention cancer pain. They exist for a whole bunch of stuff, and that's what you want to address.
Why do they prescribe Cymbalta for pain? I thought it was an antidepressant.
Right. As we sort of mentioned a little bit earlier, the pain pathways end. The pain end in the brain where emotions are. So by giving an antidepressant, like in the setting of fibromyalgia and things like that, you're improving the neurotransmitters that are affecting emotion, but those are also now down-regulating the pain sensation that your brain perceives to the rest of the body.
But why aren't all of the antidepressants used for pain and only that?
In the setting, probably they all have some pain relief effect. Specifically for Cymbalta, they went for the pain indication. They actually, when they applied to the FDA and did their studies, they looked at that specifically. In part, there are different classes of antidepressants. Some are they call the serotonin reuptake inhibitors, the SSRIs, and there are other classes. The ones that affect other neurotransmitters, not just serotonin, but norepinephrine and dopamine. It's the norepinephrine which has the highest amount of pain relief, and so it's a mixed one, so it gives more norepinephrine. But they all do somewhat help. But the reason is more from marketing what was approved by the FDA.
How about the Celebrex?
Celebrex sort of falls into the family of the non-steroidal families. It's more specific, has supposed less GI side effects, anti-inflammatory, analgesic. Safe, but can bleed, has the same potential risks and black box warnings as all NSAIDs as a class, which is like Advil and Motrin. All right, we'll hold the questions until later so we can get Dr. Berman, because I actually have patients scheduled in another hour plus, so I got to make sure she gets to speak and then we can do more questions.
Hello, everybody. Can you all hear me? Hello, okay. I'm Dr. Frances Berman, by the way. I'm a clinical psychologist with a private practice down in Miami Beach. Most of my practice deals with geriatric psychiatry and psychology, so I work with people pretty much over the age of 65. I'm lucky enough to be able to be part of the Heber Homes Network, and I have patients at 2 of the different facilities, and I can honestly say I absolutely love working there with the clientele that I have. I can't say enough about either of the facilities, or any of them for that matter. They're absolutely wonderful, and the level of patient care there is excellent. So I'm actually very proud and honored to be able to speak on the behalf of the network, because it's a place that I consider to have some of the utmost care for the residents, and the people are treated so humanely there and wonderfully there. So what I want to start by saying is that the fastest growing population in the US right now is adults over the age of 65, and that population is expected to double in the next 20 years or so. What the National Institute on Drug Abuse states that older adults use prescription medications 3 times more regularly than the general population, and also sometimes have the poorest compliance rates. What that means really is, are we taking it the way it's prescribed, in the dosage that it's prescribed, and oftentimes as long as it's prescribed. So what we're finding is that adults over the age of 65 have some of the most serious problems with prescription drug abuse. And we sit here and we say, how can that be? But the studies show really now that some of the highest rates of incidence of overusing prescription pills comes with the over 65 population. Pain pills, tranquilizers, antidepressants are the most commonly used by the senior population. And with so many prescriptions available on the market to treat common pain and chronic pain, it's easy to see that older adults are having more serious problems. Most seniors take in between 4 to 9 pills a day, both prescription and non-prescription. And oftentimes abuse is difficult to spot. There's now, with the pharmaceutical companies are luring us into using different medications. Sometimes we have money off different prescriptions, or free prescriptions for a week or so. And one of the major companies, let's say Ambient, was offering patients a week to be able to, of getting free medications so you can sleep wonderfully and be stress-free for a week. And it's free. But what they're not telling you is that it only takes a week to get addicted. And what happens often after that, when we stop taking that kind of medication, we can experience different side effects, the jittery feelings, the anxiety, the difficulty sleeping. So what do? We go to our doctors and we say, I'm having all these symptoms, I can't stand it, I'm crawling out of my skin, I'm anxious. So we get a pill like Xanax or something else for our nerves, and the cycle continues. Some of these medications are very, very difficult to get off, and stopping them on your own can have some very serious consequences. One of the things that we always need to be aware of, any medication that you get, you need to check with your doctors before you decide to stop it on your own. Of course, utilizing some common sense, if you're taking something and you're getting violently ill, obviously call the doctor, but some of these medications really need to be lowered or titrated down, and just stopping them cold turkey can have some very detrimental and serious effects. One of the other problems is, as we get a little bit older, we're considered to have more side effects from some of the medications we get than some of our younger generations. So oftentimes we're prescribed doses in lesser amounts, but sometimes it doesn't help us. So we end up taking a little bit more maybe, or an extra pill here and an extra pill there. And what we don't realize is that that can be the pathway to abuse and over-medication. We're now in the area here of the baby boomers, really. We've reached seniority. We were all taught to think we're gonna have a pain-free life. We're baby boomers, life is wonderful. We're not expecting any chronic pain. We're not expecting any illness. But yet, as we get older, we see that life does bring about a lot more illness and a lot more chronic pain. The reason, the question then arises, why do we as seniors sometimes start to abuse some of the medications? I mean, after all, these are the golden years, right? I mean, that's what we're told. These are the golden years. And one of the psychiatrists that I work with always says, the golden years, huh? I think they're a little bit tarnished. That's how he says it. As we get older, we're dealing with different issues. We're dealing with financial issues. We're dealing with a decreased support system. People are dying. My mother-in-law calls me and tells me I have another funeral to go to. She says to me that she goes to more funerals now than she does birthdays. And she finds herself constantly having another funeral to go to, sometimes 2 in a week. So all these things and poor physical and mental health, and some of us are caregivers. Some of us are caring for our partners, perhaps, who are not doing as well as we are. And that brings about a tremendous amount of stress. Is anyone here a caregiver for somebody or has been? Not an easy place to be. Not an easy place to be. And in the midst of that, oftentimes we forget ourselves. And that's something that we have to really recognize, that while we're caring for others, we still need to care for ourselves. Because if we don't, how can we care for the others? We have a lot more health problems as we get older, which can result in the need for different kind of medications that have the potential for abuse. We have a problem called self-medicating. And we have the reasons for it: arthritis, as Dr. Raddick said, osteoporosis, orthopedic surgery, insomnia. These are just a few of the gifts that we get when we become senior citizens, unfortunately. Of course, this happens younger as well, but we get it in a nice abundant supply as we get a little bit older. Sometimes we have the slips and falls. Studies show that 25 to 45% of the older adult population suffer from chronic pain of some sort. And abuse can begin very harmlessly. Sometimes we may have medications in our cabinet from other previous surgeries, let's say, or maybe there might be something in the cabinet that belongs to our husbands or our wives. And when we're hurting, we may say to ourselves, well, if you took it when you were hurting and I have the same thing, maybe it's good for me. And what we don't realize is that some of what people may be saying may be mood swings, increased falling, depression, isolation, irritability. These may not necessarily be signs of aging. They could be signs of abuse and addiction. So it's very careful, it's very important that we watch out for that. Also, as Dr. Raddick explained, as we get older, we metabolize our medications differently. So we're not taking in as much fluid, let's say, as some of our younger counterparts, and because of this, some of the medications may stay in our system longer. And if we're taking more of it and it hasn't cleared our system, we run into the potential for abuse or for some serious medical complications. We need to understand some very important terms, and Dr. Raddick went over this as well, but tolerance. Tolerance is when the body gets used to the medications we're taking and we need more to get relief. So if one pill worked before, you may be finding that one pill isn't working as well or for as long. That's when the body is building up a tolerance. Addiction is another issue. That's where we end up having poor control over the drug, the compulsive need to continue to take the medications despite any problems that may cause, and also cravings, as Dr. Raddick had described. And that's one of the key components of addiction and of overuse, is the craving to continue to take the medication. Dependence occurs when we need the drug to behave normally and to feel normally. And when some certain drugs are removed, we can go into withdrawal. And I don't know if anyone's ever experienced that, but it's a horrible feeling. And some people may have experienced that, perhaps if you've had a procedure done and you've been on, let's say, an opioid for a certain amount of time, and you stop taking that medication. Sometimes people have cramping, sometimes people have overwhelming anxiety, palpitations, insomnia, lack of sleep. All of those can be symptoms of withdrawal of the medication. So here's the real problem now. As we age, we're susceptible to more problems physically. Therefore, we're susceptible to more problems with taking medications with the potential for abuse. Another problem that we have to really focus on, and Dr. Raddick mentioned it, is staying with one pharmacy. Many people get different prescriptions and take them to different places. The problem is, the pharmacist may not know what else you're taking. So you don't know if the medication that you're filling in a different pharmacy might have some sort of drug-drug interaction, which we may go over after, whereby taking it with something else you're taking could be very potentially dangerous. So we need to remember to stay with the same pharmacist and to try to be as honest about that as possible to suffer the least amount of consequences that we can. So how do we deal with chronic pain without becoming a doctor shopping, pharmacy hopping, prescription seeking, and drug addicted senior? Well, for many of us, it's becoming more aware of ourselves and our pain level. It's being honest with yourself and understanding what it is you're feeling and being on top of it. I had dental surgery last week, and Dr. Raddick went into this a little bit. I was trying not to take the medication, and I ended up getting to a point where the pain was so severe that when I finally took it, it took so long to work, and it didn't seem to take the edge off it like it was supposed to. And that has to do with the nerve endings and all of that Dr. Raddick knows a heck of a lot more than I do. All I know is that it hurt. And I learned a lesson from that. And I think that is, with all the warnings now about overusing medications, we still need to realize that there is a place for it. And to use them appropriately, and not to let yourself get to that point where the pain is so excruciating that you can't manage it. We have to be very, very careful about that. So, we have several different types of non-invasive ways to deal with pain, and some of them were mentioned already. One might be we might end up getting a case manager who will help us. And when I say pain, I'm also referring to some of the stress that we may experience in life. Overwhelming stress can also lead to chronic pain and to abuse potential as well. So some people end up getting a case manager who handles all of their appointments, all of their financial aspects, so that they have one less thing to worry about. We also use cognitive behavior therapy as psychologists. This is when you come into the office and we work with you on trying to identify and change some of the negative thoughts and behavior patterns that may contribute to some of the physical pains and illnesses you have. We work to replace some of the negative thoughts with more positive and adaptive thoughts. For example, instead of saying, I'm miserable, my life is terrible, I'm in terrible pain all the time and I can't manage it, we work on saying different kinds of sentences like, right now I'm having a hard time, I know I'm having a lot of pain, but I need to learn how to manage it, and I will be able to. And this is quicker than if you went to a psychologist's office to work on long-term therapy. We use this to try to get a quick fix, to try to help people change their thoughts, because the thoughts have a great deal to do with how we feel. I don't know if people in here, anybody here a good worrier? I know a lot of good worriers. And we can take thoughts and go around and around and around and around, and before we know it, the problem is so magnified, and we're lost as to how to deal with it. And we have to be careful to keep that under wraps also, because chronic stress leads to physical illness. And we have to manage that more effectively. Behavior modification is used also. That's a lifestyle change. First, you go to the doctor's office, the psychologist, and a pain assessment is taken. We try to get a thorough idea of what it is wrong, how you're suffering from it, and then we get more of an awareness as what we're going to do with it. And here, we offer a reward system, and a person's efforts are rewarded for trying to make positive changes. Sometimes we pick our own rewards. Sometimes we say to ourselves, I'm going to do an exercise program, I'm going to do a diet program, and when I do all of this, I'm going to buy myself that dress I want, or that book I want, or in my case, all of those things, because I'm not good at setting those kind of limits so well. So relaxation training, when one is able to follow some of these plans and work on some of these behavioral changes, oftentimes we see a reduction in pain, or we may perceive we have a reduction in pain. Either way, if we're not feeling pain, that's okay. We also use relaxation techniques. This allows us to calm and cleanse the mind, to focus elsewhere. Patients are taught to control their pain by learning how to relax. We learn that first in the office, and we do different techniques, different soothing voices, teaching you how to relax more effectively. And once you feel that you have a good control over that, that's something you can do at home. I remember back in college, I used to become so overwhelmed at the idea of taking a test in school that I used to have to do this kind of relaxation with myself. And I would sit in the class and I'd sit there and go through my own motions just to be able to relax enough so that I was able to remember the information. Because when we get overwhelmed and overtaxed, it's very easy to forget what it is we started with. You know, we end up with two problems, the original one and the overwhelming anxiety that goes with it. So we learned also, Dr. Raddick spoke about some of the deep breathing and the guided imagery. That's where we talk about relaxing and experiencing yourself in a different environment. Oftentimes we see that on TV. Hollywood hypes it up where we say, lie down, pretend you're at the beach, think about the sand and the wind and what have you. And some people are able to really extricate themselves from the pain. And you know what? If you can go through that hour and feel less pain, so be it. That's excellent. We also learn about hypnosis. Hypnosis is one's susceptibility to suggestion. That is, we get you in a very relaxed state, we feed you different types of statements, and one is then able to gather from that and be able to utilize those statements in order to feel better. Some people who undergo hypnosis state that their pain threshold is severely limited. And others say that once they undergo hypnosis, they become less depressed, less anxious, and thereby experience less pain. Dr. Raddick went over biofeedback and acupuncture, and some of these holistic measures are really wonderful. You know, there's a place for holistic health also in the medical profession, and we can learn to utilize other ways to manage pain, not just through modern medicine, but through relaxation, through all different other types of techniques that sometimes give us the same effect. As Dr. Raddick had mentioned, Tai Chi, that's a mind-body exercise where there's gentle stretching and a series of low-impact, graceful movements, never breaking stride, and we release some of the stress through the movements. And some people find that it's a wonderful way to release stress. Some people say, a little hokey. But you know what? I've seen people take part in some of these non-invasive methods and really achieve much less stress and a better sense of managing their own bodies more effectively. Prayer. Some of the most well-adjusted people that I've met are spiritual. They pray. And sometimes for some people that feels better. We also have different support groups, Alcoholics Anonymous, Narcotics Anonymous. There are pain support groups where you can get together in a psychologist's office and people learn how to manage their pain. Sometimes the best learning you can get is from others who have been through it. The psychologists, we know some of the theoretical training and what have you, but if someone else, one of your contemporaries, has done something and has gotten a positive effect from it, that's some of the best kind of learning that you can get. And also now, with the way the world is in technology, believe it or not, there are support groups online. You don't even have to leave your house. You can go online and people can commiserate and give others ideas on how to manage their pain, and some people learn the best that way. Either way, it's about being honest with yourself. It's about understanding how much you can manage, what you're willing to do to change. And there is also a place for medicine and psychotherapy together. And oftentimes those two form a really solid way to help us manage some of our pain and overwhelming anxiety. So, with that having been said, thank you. Are there any questions that I can answer? Okay, well then we're back to Eileen.
We also have a surprise guest. Roosevelt Moore is our director of rehab, and he's going to talk to you a little bit about one piece of equipment that we have in particular that will help with pain and swelling. So I'm going to turn this over to Roosevelt. He's going to be brief, and then we're going to answer any questions that anyone has. We have like 5 minutes.
Okay. Good afternoon. Holistically, we have to treat pain in all aspects of medicine. We all have our place. As a physical therapist, one of our goals is to manage the pain. And as patients or clients, you have to realize that as you get older, our bodies loses water, we compensate, and it changes our overall bone structure. Maybe our back, our joints, our weight-bearing joints as our legs or our shoulders. The goal is for us to try and control swelling and control your pain. There's various treatments out there that would help do this or get you to a point in which it's manageable. One piece of equipment we have is called the mgmt. And what it does is it works on your neuroreceptors inside of this peripherally for your peripheral nervous system. It also vasodilates your blood vessels by sending deep oscillation of vibration or vibration. I think it went out. Vibration. I'm sorry. You okay? There we go. Yeah. So what it does, it sends vibration or deep oscillation deep down into your tissue, helping to relax your vessels by increasing the circulation, bringing nutrients to that area that would help heal the nerve endings and promote healthy tissue regrowth. As we have pain, there's obviously some type of trauma. We don't have pain for no reason. Pain is one of the ways our body lets us know that something's wrong. And the result of that pain, that the body's going to actually swell up. The area in which the pain is being, you have pain, the body swells up. And it protects you initially. But if you don't control that swelling, it's going to also lead to further trauma and further arthritis. Arthritis can come as a result of constant trauma over the years in which your body is repairing itself and the joint structure starts to change. So one of the treatment options for a therapist is to control the swelling. It's also get you to the point in which you're strong and flexible enough to support your joints and your weight-bearing areas so that the inflammation doesn't occur as frequently. And by doing so, you have managed the pain, because whenever there's swelling, it's going to pinch on your nerve endings and cause the pain. So ultimately, the goal is to find out why you're having the pain and try and treat it at that point. The HiverMat, like I said, it's one of the pieces of equipment the Plaza Network has. We're the only long-term care facilities in South Florida that actually utilizes this piece of equipment. Right now, currently, all of the NBA or National Basketball Association teams are, you can come up here. They're using this equipment as well as the Miami Dolphins. Yes, the Heat has it, the Miami Dolphins has this piece of equipment, and of course the Plaza Health Network has it. And it works wonders in terms of controlling edema and pain. And what it does, if Herman was my patient, he would hold on to this piece of, this sensor here, and I would hold, it would hook up to me, and the vibration through this machine helps vasodilate his blood vessels and move the fluid from the area in which the pain is being caused. By getting rid of that swelling, it decreases the pressure on your nerve endings, giving you pain relief. It's just one treatment option that we're using throughout all of our facilities to help individuals who have chronic arthritis and pain that hasn't subsided with traditional medicine, whether it be pain meds, hot packs, cold packs. So as technology improves, we're just trying to use all the latest technology in order to help maintain the pain. Yes. H-I-V-A-M-A-T.
I have a question. Is the Plaza an outpatient, inpatient? I mean, the rehab,
it's all inpatient at this point, but right now we're going through a transition, and hopefully we'll be offering outpatient in most of our facilities by the end of the year.
I can tell you that I have a torn meniscus in my right knee, and it was really bad. I mean, I had a hot knee, and it was very swollen, and one of the therapists used the HiverMat and some massage therapy, and I have not had surgery, and this is over 2 years, so I can attest to that. And I do aerobics. I do jazzercise and ballroom dancing, and I'm able to do it without any pain, and I'm very appreciative.
If somebody wants to try it after the questions, because Dr. Acker has to leave, but after the questions are over, if somebody would like to be treated with it, you'll feel nothing except a gentle massage. So if someone has a pain that they'd like to try it with, they're welcome to stay and try it.
Thank you all for coming. I hope that you found this very interesting, and thank you to Dr. Raddick and Dr. Berman.
okay, I need.
You want to try it?
Yes.
Okay.
I broke my wrist.
Okay. Yeah, I can see the swelling.
There they are.